Welcome to Clinical Minute. Rosa is a 53-year-old woman, gravida 2, para 2. She has mild hypertension, is overweight, and smokes 1 pack of cigarettes per day. Her mother's sister has rheumatoid arthritis. Rosa presents to your office with pain, swelling, and stiffness in wrists, hands, and feet for 6 weeks. How do you evaluate Rosa's symptoms? Rheumatoid arthritis, or RA, is a chronic inflammatory disorder that most typically affects the small joints in the hands and feet. Unlike the wear and tear damage of osteoarthritis, RA affects the lining of the joints, causing a painful swelling that can eventually result in bone erosion and joint deformity. RA is associated with pain, swelling, and loss of function. Flare-ups occur, during which there is increased inflammation and more severe symptoms. The etiology of RA is not yet understood, although it is thought to be caused by interaction of genetic and environmental factors. The onset of RA can occur at any age. It is most frequently first diagnosed in individuals ranging in age from 30 to 55, with women more likely to experience disease onset at a younger age compared with men. Evidence of radiographic bone erosion is apparent in the first year following diagnosis of RA for about 1 in 5 individuals. The inflammatory mediators associated with RA result in a number of adverse consequences, including insulin resistance, atherogenesis, acute phase response, reduced bone mineral density, and changes in brain serotonin transport and the hypothalamic pituitary adrenal axis. These consequences increase the risk of several conditions, including myocardial infarction, stroke, fractures, and depression. Individuals with RA have a higher risk than the general population of developing these conditions. They also have a higher mortality rate, mainly due to accelerated cardiovascular disease, especially in patients who have high disease activity and chronic inflammation. Care providers must screen for and treat these comorbidities to reduce the additional adverse consequences associated with RA. The typical presentation of patients with RA includes pain and stiffness in multiple joints, although approximately 1/3 of patients report symptoms affecting only one location or a few scattered sites. Morning stiffness usually persists for more than 30 to 60 minutes following initiation of activity. Symptoms develop over time for most patients, with 10 to 15% of patients experiencing rapid onset of symptoms over the course of days to several weeks. Affected joints are tender, warm, and swollen. Joints that have the highest ratio of synovium to articular cartilage are most likely to be affected. The wrists, proximal interphalangeal, and metacarpophalangeal joints are most frequently involved. The pattern of joint involvement is usually symmetric. Muscles that are located close to inflamed joints frequently atrophy, and patients may report feeling weak, fatigued, or experiencing general malaise. The differential diagnosis of RA includes an extensive list of conditions. RA can mimic any disorder that results in acute or chronic arthritis in more than one joint. Acute infection, including parvovirus B19 and bacterial infections, osteoarthritis, gout, fibromyalgia, psoriatic arthritis, other systemic diseases such as systemic lupus erythematosus, systemic sclerosis, polymyalgia rheumatica, and sarcoidosis, and chronic infections such as HIV and hepatitis C. Providers should conduct a preliminary evaluation of patients with symptoms consistent with RA. This evaluation should include the history, which should include duration of symptoms, locations, other symptoms, and family history. On the physical exam, the care provider should take note of any tenderness or swelling, its location, and other relevant findings. Labs should include rheumatoid factor, erythrocyte sedimentation rate, or SED rate, which is associated with acute inflammation, antinuclear antibody, or ANA, anticyclic citrullinated peptide antibody titer, and C-reactive protein, which is associated with acute inflammation. This figure shows the diagnostic criteria published by the American College of Rheumatology. A score of 6 or more is considered definitive RA. The American College of Rheumatology recommends that patients be screened with these criteria if they have at least one joint with definite clinical synovitis, such as swelling, that is not better explained by another condition, such as systemic lupus erythematosus, psoriatic arthritis, or gout. You conduct an evaluation. You ask Rosa about her history and learn, as previously mentioned, that she has experienced morning stiffness, pain, swelling in her hands, wrists, and feet for about 6 weeks. You learn that her mother's sister has RA. On physical exam, you find swelling and tenderness in 4 small joints, both wrists at metacarpophalangeal joints and both feet at the interphalangeal joints of both large toes. At a follow-up visit 1 week later, you review the lab results, which include a positive ANA, a low positive rheumatoid factor, a low positive anti-CCP, an elevated CRP, and a normal ESR. Based on these findings, Rosa has definitive RA with a score of 7. Does she need referral to a specialist at this point? Rheumatologists can provide a diagnostic evaluation and long-term management of RA. Early use of disease-modifying anti-rheumatic drugs, or DMARDs, has been shown to be important in preventing joint damage. Primary care providers should consider conducting an initial evaluation of a patient with possible RA and referring the patient to a rheumatologist to confirm the diagnosis and begin treatment with DMARDs. Ensure that copies of all relevant lab tests and imaging tests are sent to the specialist. Prior to the evaluation, providers can provide patient education about RA, start nonsteroidal anti-inflammatory drugs, or NSAIDs, for pain management. Ensure that the patient has a recorded blood pressure and baseline complete blood count, creatinine, electrolytes, and chest X-ray. And check patient's vaccine status and check hepatitis B and C serologies. Care providers can also consider starting hydroxychloroquine until the diagnosis of RA is confirmed by a specialist. Care providers who are confident in the diagnosis and familiar with the use of these drugs can start sulfasalazine and methotrexate instead of hydroxychloroquine. If symptoms are severe, providers can add low-dose prednisone, up to 10 milligrams per day. Providers should follow up with newly diagnosed patients monthly to monitor the response to treatment and possible side effects of medications. Care providers should contact a specialist if any concerns develop prior to his or her evaluation of the patient. You begin treatment with NSAIDs and low-dose prednisone and provide the pneumococcal and hepatitis B vaccines. You recommend that Rosa return for an influenza vaccine early in the season. You refer Rosa to a rheumatologist to confirm the diagnosis and begin definitive therapy. Rosa sees the specialist 2 weeks after her visit with you, which is 6 weeks after symptom onset. The specialist confirms the diagnosis of RA and begins methotrexate. Over the next 4 weeks, the rheumatologist increases the dose of methotrexate. 12 weeks after methotrexate was begun, the rheumatologist adds adalimumab, brand name Humira, because of an incomplete response to methotrexate alone. The dual therapy controls Rosa's symptoms. On the days she has pain, Rosa uses NSAIDs, with a maximum dose of 800 milligrams up to 3 times a day. You refer Rosa to physical therapy for an exercise program focusing on maintaining range of motion and strength training. You talk with Rosa about the increased risk of cardiovascular disease in people with RA. You ask about her current interest in smoking cessation and weight loss. You emphasize that weight loss will also help her joint symptoms. She indicates her willingness to stop smoking. She tells you she wants to try smoking cessation before trying to lose weight. You provide information on smoking cessation tools and ask her to schedule a follow-up appointment in 1 month so that you can monitor her progress. Due to the complexity of RA, providers should take into account the following. Rheumatoid arthritis is a systemic autoimmune disease. Bone damage frequently occurs in the first year following onset of RA, emphasizing the importance of early diagnosis and treatment in order to prevent disease progression. Patients with RA are at increased risk of a number of comorbid conditions. Patients with RA require regular monitoring and evaluation for comorbid conditions as one component of their long-term care plan.